Let me tell you about a patient. I will call him Marcus. He was 47, a secondary school teacher from Leeds. For 6 years, Marcus did everything right. He cut out processed food, he started running 3 times a week, he lost 12 pounds. But the belly fat never moved. His digestion was still unreliable. He was bloated after meals he could not explain. And every time he went to his GP, the answer was the same. Your bloods are fine, watch what you eat, try to manage your stress. What his doctor never told Marcus was this. The belly fat was not there because of what he was eating. And the poor digestion was not a food sensitivity. Both were downstream signals of something happening at a completely different level inside his body. Something his doctor had never been trained to look for. Something that, once we found it, changed everything in a matter of weeks. And in this video, I am going to show you the 5 hidden causes of stubborn belly fat and chronic digestive dysfunction that doctors consistently get wrong. Not because they do not care, but because the medical system was built to treat the symptom that walks through the door, not the mechanism driving it from the inside. By the time we reach cause number 4, you are going to understand something that almost no GP will ever tell you in a 10-minute appointment. And cause number 5 is the one that reframes everything at 10, including why nothing you have tried so far has fully worked. Stay with me, because this matters. Before we get into the 5 causes, I need to explain something about how the medical profession approaches belly fat and digestion. Because the error is not random, it is structural. When you walk into a consultation with bloating, abdominal fat that will not shift, and a digestive system that seems to have a mind of its own, a doctor is trained to look for the most obvious explanation: caloric excess, irritable bowel, stress. And if your blood work comes back within normal range, the conversation usually ends there. What that conversation almost never includes is this question: is there an inflammatory process running silently in your body that is driving all 3 of these symptoms at once? Because here is what we now understand from a significant and growing body of research. Belly fat is not simply the result of consuming more than you burn. Chronic digestive dysfunction is not simply a gut problem, and the 2 are not separate. They are both outputs of a shared biological mechanism. That mechanism is systemic inflammation, and systemic inflammation has 5 specific sources in most of the patients I see with these presentations. None of them show up on a standard blood panel. None of them are addressed by calorie restriction or antacids, and doctors are wrong to keep treating the visible symptoms while every one of these root causes continues to run unchecked. Let me show you what those 5 causes are, and more importantly, I want to show you the mechanism, not just the what, but the why. Because when you understand the mechanism, the solution becomes obvious. Now, the first cause is one that surprises almost everyone I explain it to, because it reframes something you think you already understand. We tend to think of belly fat as passive, as stored energy waiting to be burned, as something your body accumulates when you eat too much and that disappears when you eat less. That model is incomplete, and for a significant number of people, it is the reason nothing they try ever works. Visceral fat, and the fat that sits deep in the abdominal cavity around your organs booth, is not passive storage, it is metabolically active tissue. It contains immune cells, and those immune cells continuously produce proteins called cytokines. You can think of cytokines as inflammatory hormones. They circulate in the bloodstream, they travel through the body, and they do 2 things that are directly relevant to everything we are talking about today. First, they damage the lining of the gut wall. The gut wall is designed to be selectively permeable. When cytokines from visceral fat chronically inflame that lining, the barrier becomes compromised. Bacteria and undigested particles begin crossing where they should not. The immune system in the gut, which is the most concentrated immune territory in the entire body, goes into a state of alert. And that alert state produces more cytokines, which travel back to the visceral fat, which produces more cytokines. It becomes a loop. Second, those same cytokines signal to the brain in ways that disrupt the hormones controlling appetite, metabolism, and fat storage. And under perceived threat, the body does not release fat reserves. It holds them as a survival mechanism. This is not a minor finding. A meta-analysis published in Obesity Reviews, covering data from over 170,000 participants, found a robust and consistent association between visceral adiposity and systemic markers of inflammation. Not subcutaneous fat, the fat under the skin, visceral fat specifically. So here is the clinical implication. Marcus was not failing to lose belly fat because he lacked willpower or was eating the wrong things. He was failing because the belly fat itself was producing the inflammation that was preventing its own removal, and that inflammation was simultaneously disrupting his gut. The question is, what triggered the visceral fat to become inflammatory in the first place? And that is where the other 4 causes come in. Moving on to cause number 2, which in my clinical experience is the one patients find hardest to connect to their symptoms. Because it happens invisibly, it produces no acute pain, and standard medicine has almost nothing to say about it. Inside your gut, you have somewhere between bacteria primarily. Some of them are essential to your health. Some of them, if they become too abundant, are not. The balance between these two populations is what we call the microbiome. And that balance is fragile in ways that most people do not appreciate. Here is the mechanism that matters. The gut wall I described a moment ago has to be permeable by design. Its job is to extract nutrients from food. That means it cannot be a perfect seal. It is a selective filter, and concentrated directly behind. A significant proportion of your entire immune system sits in the gut wall, monitoring everything that crosses from the intestinal cavity into the bloodstream. When the microbiome is disrupted, when hostile bacteria become more abundant, when diversity collapses, when the balance tips, and because the gut wall's permeability increases under that response, the very bacteria the immune system was trying to contain begin crossing the barrier in greater numbers, which triggers more immune response, which produces more cytokines, which drives more visceral fat activation. What disrupts the microbiome? Ultra-processed food is the most significant single factor. A landmark study published in Cell in 2022 found that a diet high in ultra-processed food reduced microbiome diversity without 2 weeks of consistent consumption. Chronic stress is the second factor, and I will come back to that in cause number 3. Certain antibiotics, a lack of dietary fiber, and critically, the kind of low-grade persistent gut wall damage that comes from the cytokines already circulating from visceral fat. You can see how these causes do not sit independently. They amplify each other, and that is exactly why treating any one of them in isolation tends to produce only partial results. For Marcus, a stool analysis revealed significantly reduced lactobacillus and bifidobacterium populations with elevated levels. Now, this is the cause that almost everyone who hears it dismisses at first, because we have been taught to think of stress as a psychological experience, something you feel, something you manage with better habits or therapy or a holiday. But stress is not primarily a mental event. It is a biological one. And the mechanism it activates is directly connected to everything we have discussed so far. When your body perceives a threat, whether the immune system responds, not metaphorically, literally. Research using animal models has demonstrated consistently that psychosocial stress. Studies in humans show that elevated perceived stress is associated with increased levels of interleukin-6 and tumor necrosis factor alpha. Here's what that means practically. If you are living with chronic low-grade stress, which describes the majority of adults in their 40s and 50s in clinical practice, your body is continuously producing the same inflammatory hormones that visceral fat produces. They add to the inflammatory load, they reach the gut wall, they increase intestinal permeability, they disrupt the microbiome's immune environment, and they signal to the brain in ways that increase cortisol, which promotes visceral fat accumulation. Cortisol, which is released in response to stress, specifically promotes the deposition of fat in the abdominal region. This is well established. What is less commonly explained is the mechanism behind it. Cortisol increases cytokine sensitivity in visceral fat cells, making them more responsive to inflammatory signals, and more resilient to the metabolic processes that would normally release stored fat. Marcus told me he had been under sustained professional pressure for 3 years before his symptoms became severe. He had not connected the two, his doctor had not asked about it, and yet the biological chain was clear. Chronic stress. But here's what I need you to understand before we reach cause number 4. The stress response does not require a catastrophic life event to trigger this cascade. It requires persistence, a background hum of pressure that never fully resolves. That is enough to keep the inflammatory system running. And that is what most of us are living with. I want you to think back to the last time you sat in a dentist's chair. I want you to think about whether your dentist and your GP have ever spoken to each other about your health. What about whether your dental records have ever been reviewed alongside your blood work? They have not. Because in the medical system as it is currently structured, your mouth is not part of your body. It is the province of an entirely separate profession, with separate records, separate appointments, and almost no communication with the physicians managing everything below the neck. This is one of the most consequential structural errors in modern healthcare, and it has a direct, measurable impact on belly fat and digestive health in a way that almost no patient I see has ever been told about. Gum disease, the formal term is periodontal disease, affects it all. Most cases are low grade. They cause no significant pain. Gums bleed slightly when brushed. There is some mild recession. What is not explained is this. Periodontal disease is a chronic infection. And like any chronic infection, it triggers systemic cytokine release. The end. The inflammatory response in the gum tissue does not stay in the gum tissue. It enters the bloodstream. And from the bloodstream, and adds to the inflammatory load that is already being generated by visceral fat and microbiome disruption. A meta-analysis published in the Journal of Clinical Periodontology, drawing on data from more than 40 studies, found a significant association between periodontal disease and elevated systemic inflammatory markers. These are the same markers we measure when assessing gut inflammation and metabolic dysfunction. And the connection extends further than that. The same inflammatory pathway that links gum disease to gut dysfunction has been investigated in relation to cognitive decline. The mechanism proposed is the same: cytokines from the oral infection reaching the brain through a barrier that medicine long assumed was impenetrable. Because it is cause number 5, and it is the one that changes how you understand everything else we have discussed today. For now, I want you to do something simple after this video. Look at your gums in a mirror. If they bleed when you brush, if you see recession around any teeth, if you have not had a periodontal assessment in the last 2 years, that is not a dental issue. That is a systemic inflammatory issue. And it may be silently contributing to the belly fat and digestive dysfunction you have been unable to explain. Marcus had undiagnosed mild periodontal disease in 3 quadrants of his mouth. No pain. No significant symptoms. Now, I need to tell you something that most medical schools are still teaching incorrectly. And I say that not to be provocative, but because the evidence has shifted significantly in the last 15 years, and the clinical implications of that shift are enormous. The brain is protected from the immune system. There is a structure called the blood-brain barrier that sits between the bloodstream and the brain tissue. And it prevents inflammatory proteins, immune cells, and cytokines from crossing into the neural environment. That is not true. The blood-brain barrier exists, but it is not a wall. It is a filtered portal. And cytokines, the same inflammatory hormones produced by visceral fat, by a disrupted microbiome, by chronic stress, and by periodontal disease, cross that portal. Research published in Nature Reviews Neuroscience and multiple subsequent studies has demonstrated the routes by which inflammatory proteins reach the brain, through specific transport mechanisms in the barrier, through the vagus nerve, and through regions where the barrier is naturally more permeable. Once inside the brain, cytokines interact with neural circuits. And here is what that interaction produces. Brain imaging studies have shown clearly that elevated systemic inflammation alters the... In animal models, inflammation-induced behavioral changes, reduced exploration, reduced social interaction, reduced movement. Here is the clinical consequence of this for belly fat and digestion specifically. The hypothalamus, which governs metabolic rate, hunger signal. When cytokine levels are chronically elevated, the hypothalamus shifts its signaling in ways that favor fat retention, increase appetite for energy. The body is not broken. It is responding rationally to what it perceives as a state of threat. But the threat is internal. It is the inflammation itself. And because the inflammation is coming from multiple sources simultaneously, all 5 of the causes I have described today, the signal reaching the hypothalamus is continuous. There is no acute spike to recover from. There is a background roar that never quietens. And a body living in that state cannot metabolize fat efficiently, cannot maintain gut wall integrity reliably, and cannot regulate digestion normally. Not because of what you eat, because of what your inflammatory system is continuously telling your brain. This is why Marcus's belly fat did not respond to diet and exercise. His inflammatory load was too high. His brain was receiving signals that until we address the inflammation at source, nothing else was going to work. And that is what I want to show you how to do now. Here is how I would approach this if I were sitting across from you in clinic today. The first thing I would do is request a C-reactive protein test. This is a blood marker of systemic inflammation. It is not part of a standard blood panel in most countries. You have to ask for it specifically. A result above 1 milligram per liter, and particularly above 3, suggests chronic low-grade inflammation that warrants investigation. The second thing I would do is refer you to a periodontist, not a general dentist, for a full periodontal assessment. If you have undiagnosed gum, and unlike most interventions, it has no significant side effects and takes no lifestyle overhaul. It is mechanical, it is locatable, and it works. Several of my patients have seen measurable reductions in CRP within 8 to 12 weeks of periodontal treatment, alongside improvements in bloating and digestive regularity. The third thing I would address is ultra-processed food elimination. Not calorie reduction, not a specific diet. One focused change. Remove foods that contain more than 5 ingredients, particularly those containing emulsifiers, artificial sweeteners, and refined seed oils. These are the dietary inputs most consistently linked to microbiome disruption in the current literature. A paper published in Nature in 2015 demonstrated that common emulsifiers, specifically carboxymethylcellulose 80, and increased intestinal permeability within 12 weeks. Subsequent human studies have supported this association. You do not need a sophisticated protocol. You need a targeted one. These 3 starting points, measuring your inflammation, addressing the oral source, and removing the dietary inputs that damage the microbiome, address 3 of the 5 causes we have discussed today. And addressing 3 causes simultaneously produces results that no single cause intervention can match. Marcus did all 3. Within 6 weeks, his CRP had dropped from 4.2 to 1.8. His bloating had reduced significantly. His digestion had stabilized. And he had lost 11 centimeters of abdominal circumference without changing his exercise routine, without calorie restriction, by addressing the inflammatory sources that had been running silently for 6 years while every other approach tried to manage the symptoms they were producing. Your gut is not just a digestive organ. It is the most immunologically active tissue in your body. It is the interface between the outside world and your internal biology. And it is directly connected through the cytokines it produces and the signals it sends to every other system we have discussed today. When the gut is compromised, nothing downstream works as it should. Belly fat accumulates and resists removal. Digestion becomes unpredictable. And doctors who treat any one of these in isolation will get partial results at best. The medicine of the future will be integrated. It will ask not what symptom is present, but what mechanism is driving it. And it will look at the gut, the microbiome, the immune system, and the brain as one connected system, because that is what the science is telling us they are. For now, you do not have to wait for medicine to catch up. You have 3 specific places to start. Get your CRP measured. Get your gums properly assessed. Remove the dietary inputs that are disrupting your microbiome. And if you want to understand the next layer of this, what to eat to actively repair the gut wall and support microbiome recovery, that is the subject of my next video. Type the word inflamed in the comments if any part of what I described today matched your experience. I read every comment, and your response tells me what to cover next. This video is for educational purposes only and does not constitute medical advice. Marcus is a composite of clinical patterns drawn from patients in my practice. Consult your physician or a qualified gastroenterologist before changing any supplement, dietary protocol, or medical treatment. The information presented here reflects current research literature and does not replace individual clinical assessment. This content is produced by an